All right. Well, good evening and welcome, everyone. Thank you so much for joining us for our Wellness Webinar Series event with Jefferson Health. My name is Sarah Breckville, and I will be serving as your program facilitator to help present your questions to our panel of physicians. These experts from medical oncology, urology, and family medicine will discuss the importance of not delaying your care. Prioritizing our health is critical and will cover screenings, treating illnesses sooner rather than later, the importance of listening to your body, and putting your health at the top of your to-do list. Remember, the steps you take today are your first steps to a healthier tomorrow. Well, thank you so much for submitting your questions in advance. And if you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A, and you can enter your question right there in the text box. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases or the number of patients we have treated or are currently treating. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate that annoying background noise, so feel free to move around and get comfortable. So with that, let me introduce our experts and stars of the show for the evening, starting with Dr. Ida McKiley from Medical Oncology, Dr. Patrick Gamella from Urology, and Dr. John Russell from Family Medicine. So thank you all for joining us this evening. And I think with that, we'll get right into the questions. So Dr. Russell, we'll go ahead and start with you. You'll have first question. Okay. The question to kick us off: when should someone see a primary care physician versus seeing a specialist? For example, maybe if someone is experiencing a rapid heartbeat.
Yeah, I think that's a great question. I would make a little pitch. I think everyone should have a primary care clinician that they could call. And I think part of the thing is a little bit of this kind of mentality that we're all in separate silos. So Dr. McKiley, Dr. Gamella, and I, we don't talk to each other, we don't work together. And there are a lot of things that we can do in concert. So you might not have a cardiologist you could see that day. Maybe you can see me the same day. Maybe if I'm seeing you with a rapid heartbeat, maybe I'd check a blood count, maybe I'd check your thyroid, check an EKG, and we could discern, is this something that I can just treat today? Is this something that might need to go to the emergency room? Or is this something that needs to see a cardiologist? But the cardiologist will be armed with some of the information that I got today, just like if I was referring to someone with a malignancy onto Ida or someone with a urologic condition onto Patrick. At least if I could get some of the beginning work done, it's a one visit maybe for them or two visits, but we've at least gotten some of the groundwork out of the way. But I think it's a great question.
Okay, great. I guess moving along with that, to your point of working in concert and working together, Dr. McKiley, what would you say are the most important screenings someone should get? And are there different screenings for men and women and different age groups?
Yeah, thank you for your questions. So there are several age-appropriate cancer screening recommendations out there so that we can try to catch cancer early. So let's review, I guess we'll do the American Cancer Society guidelines because that's my wheelhouse. So for women, let's start with cervical cancer. So one of the really crucial preventive screening tools is the pap smear and testing for the human papillomavirus or HPV. All women between the ages of 25 to 65 should undergo routine screening for cervical cancer with HPV tests every 5 years, or you could do a pap smear every 3 years. Some organizations even advocate for starting as young as 21 years of age. And an annual exam by your gynecologic provider is highly recommended. Next, let's talk about breast cancer. So when it comes to breast cancer screening, it's a bit nuanced. So I will just start by saying that it's really important to talk with your provider about the potential benefits and the potential limitations in breast cancer screening. The current recommendations are that women between the ages of 40 to 49 should really have a discussion with their providers about the consideration of a mammogram every year. Between 50 to 54, certainly mammogram every year. And then between 55 and 74, we loosen that recommendation to either every year or every other year. Now, I say this with the stipulation that there is a population of women that are considered to be high risk due to family history and genetic predispositions. And these women may initiate screening at an earlier date or receive more frequent mammograms or other types of testing as well. And this should really be discussed with Dr. Russell, your primary providers. We're certainly here for medical oncology to talk about it too. A really important recent change in our world of oncology for screening has actually been in colon cancer. I know that this has been really all over the news, unfortunately, with some stars who caught colon cancer very early in their lives. So one of the really most important changes that has been that we've actually advocated for earlier screening for colon cancer. So colon cancer screening in the general public should now start by the age of 45 by either colonoscopy or stool testing, and that should continue until at least the age of 75. But again, there are some high-risk individuals that might start younger, and this should again be discussed with your providers. Now, I'm a lung oncologist, so I have to talk about lung cancer screening. So lung cancer screening is done with a low-dose CAT scan of the chest. That happens for individuals who are between the ages of 50 to 80 who have a history of smoking either currently or who have quit in the past 15 years. They've smoked roughly the equivalent of about a pack a day for about 20 years. So I will just interject and say, if you are currently smoking, please talk to your providers, talk to us, let us know how we can support you in your efforts to quit smoking. And, I know Dr. Gamella is certainly going to talk about this some more. Prostate cancer is one that should be really discussed. The screening should be discussed with your providers. Similarly, uterine cancers in the same bucket. There's no universal screening recommendation currently, so this should really be talked about with your providers at around the age of 50.
Okay, thank you. A lot of really valuable information there. I think, people definitely have to come back to this YouTube video once it's posted to get that information, because that was incredibly helpful. So thanks so much. And especially for those, recent updates. All right, let's turn to Dr. Gamella now. Dr. Gamella, a more specific question from you from the audience. Are there any treatments for incontinence?
Of course, and thank you for inviting me here tonight at this webinar. Really, it's a great chance to meet everyone. Even though I can't see all your faces, thanks for joining us tonight. So this, the topic of incontinence, certainly something that, me as a urologist is not embarrassing anymore, but I know a lot of folks are very embarrassed talking about incontinence, and this is something that you should not suffer silently with. If it's something that's new or something that's been ongoing, certainly reach out. So when we talk about incontinence, it's helpful to define what incontinence is. Obviously, it's leakage of urine. There's two general types that we see, stress incontinence and urge incontinence. When they're combined, we call it mixed incontinence because you can have both. Stress incontinence is leakage of urine with activities. It's much more commonly experienced by women, especially women who have had children. So you do jumping jacks, you get up from a seated to a standing position, you go running, you sneeze, you leak a little bit of urine, and that's stress incontinence. Urge incontinence is really what's more associated with what can be an overactive bladder. So some folks just simply have a sensitive bladder, whether that be to certain dietary reasons or otherwise. And that's just where your bladder squeezes when you're not quite ready and you leak a little bit of urine. So that's not associated with activity. Now, obviously, as I mentioned, you can have both of these. There's also incontinence we see after certain procedures, particularly radical prostatectomy for prostate cancer, which is typically a stress urinary incontinence. So depending on the type, there's many different options and treatments available. In general, as in medicine, I feel we at least I try, even though I'm a surgeon, I try the most sort of conservative, low risk treatments first, and that's no different for incontinence. So for easy, really low risk interventions include dietary and behavioral modifications. So that's something simple as minimizing your caffeine intake, or reducing your caffeine intake. I'm certainly a coffee junkie, so I don't tell patients to cut out all caffeine because that's not realistic. But, if you're drinking 4 or 5 cups of coffee a day, and you're experiencing some leakage, one of the things you can think about is cutting it back to a couple cups a day, or at least maybe switch to decaf for some of those. Behavioral just include things like Kegel exercises, as well as sort of, just being mindful about your bladder health. And if you're going to be away from a bathroom for a while, maybe you take that one stop at the restroom before you go. Now, medications are available if these strategies don't work. So we do have several different treatment options and for this. For stress incontinence specifically, surgeries are available also, and they really depend on the sort of how bad the leakage is, and what the cause of the leakage is. These include things, something called urethral bulking, where you sort of bolster the urethral sphincter from the inside, all the way up to something called a sling, which supports the urethra, typically with mesh or your natural tissues. And a gold standard treatment is something called a urinary sphincter, which is sort of a mechanical device that helps prevent leakage. And I would be remiss to not mention, I'm sure some people have seen in the news, it was popular about 6 weeks ago. There was a news story out of New York about the Hampton bladder. And that was a news story about people in downtown Manhattan going to a urologist to get their bladders injected with Botox. Well, it was kind of sensationalized. Botox, which is most commonly used for wrinkles, as well as migraines and sweating, hyperhidrosis, et cetera. We actually used it as a third-line treatment for overactive bladder and urinary incontinence, where we inject that same medicine into the bladder to help quiet it down. So definitely lots of options available for you.
Certainly a lot of options. Thank you for these, late breaking news updates. Very interesting to hear about that one. But I think also good news to hear for those coffee drinkers out there that we don't have to cut it out completely. So thank you for that. All right, Dr. Russell, we'll go back to you. Definitely a top of mind question for a lot of people with so much happening in the world right now, including COVID. So how can people best handle stress and anxiety? Oh, I think you might be on mute.
Oh, sorry. So that's certainly the $1,000,000 question. And one is just kind of acknowledging it, right? So, we're all stressed. We're all a little bit depressed. COVID has certainly taken the wind out of everyone's sails, right? So partly is the way to start addressing a problem is start to acknowledge it. So one is kind of saying, what's triggering your anxiety? And there's a great thing that we live in a 24-hour news cycle. There's a bad thing that we live in a 24-hour news cycle, and that you could be watching every inch of this hurricane kind of moving up the map, or whatever else you're watching on. So one is really turning off the television. So if I turn off the television, what I'm going to do? Well, maybe get a little exercise, get some of those kind of positive things going. Maybe have something to eat. Maybe have something to eat that's pretty good for you, right? So we're sitting on a computer right now, and that was kind of that garbage in, garbage out philosophy with computers, right? If you put bad programs on your computer, they're not going to run real well. If you're super anxious, if Dr. Gamella is super anxious, I might say, maybe 5-6 cups of coffee might be a little bit too much, right? Maybe cut back a little bit. Maybe you could do some of those things. Sleep. We live in this incredibly weird world where sleep doesn't seem to be important. It's macho to say, I only sleep 3 hours a night. That's really not true, right? We're mammals. We need to sleep. We need to do these things. And also a thing I think is really important is some mindfulness, a little bit of meditation, closing your eyes, picturing that really great place, breathing in and out. All that stuff can help. None of those things I just mentioned involve the doctor. Right. And then if you feel at that point, you still go talk to someone, talk to your primary care doctor. Maybe they have a therapist in the office as I do. Maybe they can refer you on to a therapist. Maybe it's talking to a friend. Maybe it's talking to a clergy, but sometimes talking can help a great deal for this. So these are all some simple things, but anxiety is something we all have a bit of.
Absolutely. And I think it's comforting maybe to hear your first point that, we all are experiencing anxiety to a degree. So just to know, it's not easy right now and we're kind of all in this together. So thanks for flagging that. But you're not done. I have another question for you.
I'm ready.
Still keeping along the lines of anxiety. How can you tell the difference between anxiety and maybe cardiovascular issues?
Yeah. I mean, I don't think someone without evaluating you should kind of pat you on the head and just say you're anxious, right? And that harkens back to 100 years ago when women were hysterical, right? And that was a disease. And so someone really should make sure it's something not kind of more serious before kind of the default. And we really shouldn't be living in this world where someone's saying, boy, this is kind of all in your head. And anxiety is real, and it creates adrenaline and all these other things. But I think, especially in the age, if I'm 24, I'm probably not having a cardiovascular thing. I'm 74. I would hope that someone would not start at anxiety and work backwards.
Okay. Thank you so much. Very helpful information there. All right, Dr. McKiley, let's turn to you. An overarching question, but certainly an important one. What are the most important things to know about wellness care and taking care of just your overall health?
Yeah, I think this is a really important and excellent question. Wellness as an idea is really complex, and it includes so many different facets, right? It includes our physical, emotional, our mental, our spiritual, and social health universes, right? But that's all individualized. And I think what's important to know is that all of us here and all of your providers out there are really here to support you into finding that right balance, so to speak, so that you can live a well-rounded life. And the point of all of that, Dr. Russell was just talking about anxiety and, how, in my world, although I already see people who are sick, they also have anxiety too, because they're sick, or maybe not because they're sick. Maybe they had anxiety before they were sick. What's important though, with anxiety and health and just everything we talk about is to let us help you so that we can address this in a way that's most meaningful to you. So I want you to feel empowered to discuss with your providers what your goals and aims are for wellness and health so that we can support you to try to achieve those. Now, generally speaking, since it's a general question, we suggest an active lifestyle. We suggest this well-balanced diet with fruits and vegetables. We offer really excellent supportive services in the Jefferson enterprise for nutrition and therapy, just like JR just said, to reach your goal weight or to strive for a healthy weight. When it comes to disease prevention from a cancer doctor's perspective, I have to tell you, so limit your alcohol use if you can, and stay away from smoking altogether. Protecting your skin is also really important with protective clothing, with sunblock, and also with annual exams of your skin. And don't forget your dental, your eye, your foot health. All of that is important for all of us. And, I've been talking a lot about screening tonight, so I have to just say this, to empower you, really should recommend that you get to know your family history and therefore your potential risk for disease. I think it's really important in my world for oncology and also for cardiovascular health. That knowledge of just knowing what exists already in your family can be really empowering.
Okay, great. Thank you. We have some homework tonight for sure. All right, let's switch gears here a little bit and turn to Dr. Gamella. A little bit more of a specific question we received from the audience. What is the best way to care for a dropping uterus?
So the medical term for this is prolapse. And there are several organs. It's not just the uterus that can be an issue. Obviously, primarily we're talking about women here, but you can have the bladder can prolapse, the vagina can prolapse, the uterus can prolapse, the rectum can prolapse, and even a piece of small bowel can prolapse. So step number one is to say, well, it may not be the uterus that's dropping. So you need some help from your doctor to kind of evaluate and see what exactly is going on in your specific case. The problem is a lot of the signs and symptoms of prolapse, kind of all of these that happen, overlap each other. Things that are very commonly reported are this feeling of sort of pelvic fullness or pressure. The obvious physical sign of seeing a bulge in the vagina that you haven't seen before or seems abnormal. This can go along with leakage of urine and incontinence, like we discussed earlier. There can also be changes in your bowel patterns and habits. You could start having difficulties having bowel movements. You can also have lower back pain. And obviously, as you know, my colleagues know, there's about 101 different reasons for lower back pain. Certainly, a pelvic organ prolapse is not at the top of many folks' lists. Certainly rare, but it is a possibility. As discussed previously, we start sort of conservative and work our way up. So, you know, changes in diet and exercise, and as well as some additional medications can help. You know, pelvic organ prolapse is not really an emergency 99% of the time. It's more of sort of an inconvenience and just provides an extra challenge in your life. But again, it's not something you should suffer with if you have it. So if you have urinary issues, things like decreasing your fluid intake or minimizing or just being mindful. If you have issues having bowel movements, increasing the fiber intake in your diet, either by medications or diet. And the big one is if you are overweight, there is data and evidence to suggest that if you lose some weight, you may solve some of your symptoms that you're feeling. Additionally, there's something called Kegel exercises, which are really just exercises targeted at strengthening the pelvic floor, which are also used in some settings. When all these things don't work, we do have a non-surgical option. It's called a pessary, and there's about 30 or 40 different styles and types of pessaries. They're simply they're temporary implants that are fitted to you individually into the vagina that provide the support that is lacking in the pelvic floor. And most women actually do very well with that. They stay in long term. They do need a little bit of maintenance and some checks every once in a while, but it is a very low risk non-surgical option. When all else fails, there are surgeries that are available. We do have fellowship trained female pelvic reconstructive surgeons at Jefferson, both at our Center City location and one of my colleagues at Abington, Dr. Whitney Smith, who performs these surgeries. There's different kinds of surgeries. It's a little out of the scope of this discussion, but obviously if you have any questions, make a visit with a urologist. But they're essentially surgeries to help sort of improve or bolster the loss of support that the pelvic floor has gone through. And certainly if you suffer with this, please reach out.
Okay. Thank you so much. A lot of options here, which I think will be very reassuring for some of our viewers. So thank you so much for taking us through that. All right. Before I turn to you, Dr. Russell, I just want to say we'll be doing a few more questions that we receive, but then we'll jump to our live questions. We appreciate it. We see these coming through and they're great. So hang on tight for just a minute here, but let's just jump into a question concerning fatigue after COVID. So Dr. Russell, a question for you. Do you have any recommendations on dealing with feelings of tiredness after going through COVID? And at what point should someone see their primary care physician or a specialist when dealing with long COVID symptoms?
Yeah. So long COVID is real. And, you know, and I think people have tried to kind of make it that it is not real. And it truly is real. And we've had other viral illnesses that have had prolonged fatigue. And this involves probably some T cells, white cells that lives in Ida's realm a little bit. But this is a real thing. Fatigue is probably one of those manifestations. But So the first year of COVID, when we didn't have a vaccine, people tended to kind of have a bigger burden. The kind of the earlier strains, pre-vaccine, and people had real fatigue. The sicker people were, the more likely they were to have manifestations 60 days later. But there were kind of young, healthy people who got COVID and just didn't feel right, had brain fog and fatigue. Sadly, not a test, sadly, not a great cure. And we're all going to sound a little bit like one-trick ponies, but a lot of the stuff for long COVID is really a bit of this lifestyle, downshifting a little bit, getting enough sleep, limiting your caffeine, limiting your alcohol, eating right, getting some exercise, and kind of working through that. And hopefully it is kind of improved a great deal with more subsequent strains of COVID, or people who've gotten COVID kind of post-vaccination. It seems to be less of a problem, but it's a real problem, and we should support our patients, and we should support each other who are going through this.
Okay, absolutely. And I think it's nice to hear that things like getting enough sleep, cutting out alcohol, caffeine can in fact do the trick. So that's good to hear. All right. Well, Dr. McKiley, we will turn to you now. Let's talk a little bit about genetics and cancer. If someone has a strong family history of cancer, when should they start screenings? And I see you stretch, getting ready to answer this question.
Yeah, so this is a really important and complex topic. Our understanding of family histories of cancers and the genetic risks of cancers really are just evolving by the day. We're learning more and more every single day through various technologies and medicine. Every person has different risks due to what they were born with and or what they were exposed to throughout their life. And I know we talked about the general screening ideas of, general cancer screening things in the beginning of this hour. But we also know that certain genetic factors, either something you were born with or something that you acquired later in life, can increase your risk of cancers. And even sometimes those cancers can start at a younger age. In general, and this is a very general statement, if someone in your family has a history of cancer, we generally recommend initiating the screening for that type of cancer either at the earliest age of screening for that cancer or 10 years prior to when that family member was diagnosed with that cancer. Now, that might mean that you will therefore start screening for those cancers even earlier than the general population. But also, it's important to know who in your family might have had what types of cancers and at what age they've had cancers, because there are also possibly prophylactic procedures that your providers might be able to recommend to you to try to help prevent certain cancers from occurring. So all that is to say is the best way to know when you should start screening is to really discuss your family history with your providers. I will also just put in a plug. We have excellent geneticists in the Jefferson enterprise, and these types of tests are not as simple, just like a one-time blood test or a one-time swab in the mouth. Unfortunately, it really requires sitting down with a genetics counselor and talking through your whole history of your family. And they can recommend really comprehensive testing for you that'll be meaningful for you so that you'll have tailored approach to cancer screening and to possibly prophylactic measures to reduce your potential risk for cancer.
Okay, great. And I think I might hop in here with one of our live questions from the audience just because it's very relevant. But we received a question just now from one of the audience members that breast cancer and colon cancer run in my family. Is there a test I can take to see if I have traits or likelihood for cancer aside from just a mammogram or a colonoscopy?
So I'm so glad that you know your family history. First, want to say that to the person who put that in. Now, there are several thousands of genes out there in the world that could be involved in what we call hereditary cancers, meaning that it's something that you were potentially born with. Now, that mutations or those types of things that you were born with might increase your risk. And in order for, I wish there was just a simple blood test, but because there are thousands of genes involved, it would really serve you best to sit with a genetic counselor and talk about exactly all of the things, all of your family members who've had what diseases. It won't only be about what tests you have. Like I said, it will also impact when you have those procedures or tests done in your lifetime so that you can try to catch anything that might be coming your way as early as possible.
Okay, well, thank you so much. All right, let's get back into our submitted questions. And then again, we'll turn to our live questions. Thanks again for sending those out. They are terrific. Dr. Gamella, let's check in here with a question about getting your prostate checked. When should men get their prostate checked, and what are the signs and symptoms of prostate issues?
So it's a good additional question in talking about cancers, because in my experience as a urologist, most men who are talking about getting their prostate checked are talking about it in terms of related to cancer. Now, as men age, not everyone, but most men, due to changes in different hormones like testosterone, your prostates tend to enlarge a little bit, some more than others. The challenge is we can have some symptoms that are related to benign prostate enlargement, and you can have symptoms that are related to prostate cancer. And really, the challenge is which is which. So in general, when we talk about benign things, as we've already mentioned before, anything you can imagine with your urination, urinary frequency, peeing very frequently, waking up more than one time a night. I will say, most older men get up at least once at night to pee. But if you're someone who's getting up suddenly over the course of a year or two, 6, 7, 8 times a night to pee, that's a big sign that maybe your prostate's a little bit larger than it used to be. But anyway, I'll focus more on cancer because, again, usually when it's asked, it's in the context of getting it checked for cancer. So to sort of add to what was already discussed prior in terms of prostate cancer screening, it's certainly a very challenging topic as well. The most commonly used test we have for screening is a blood test called prostate-specific antigen, more commonly known as the PSA. This is something that came out in the 90s, used a lot. It helped in many ways, and then kind of over the last 10 years, due to some guideline changes, in some places is less used. But in general, we recommend sort of starting to discuss prostate cancer screening at age 40 to 45. In men who are at high risk, which right now primarily include African American men, and men with a first-degree relative with prostate cancer. That's really, your dad or a sibling who is diagnosed with prostate cancer. We recommend screening to start or getting your PSA checked at age 45. Now, screening can include also a digital rectal exam, which has fallen less out of favor. So don't let that sort of dissuade you from getting your prostate screened. It's certainly a part of our workup as a urologist, but certainly starting the conversation with your primary care doctor. It usually just involves a blood test. In men at average risk, we recommend starting at age 50. The same recommendations apply, though, if you have a family history of early onset or metastatic prostate cancer. Or especially if you're a patient that has a known susceptibility gene, we recommend starting to test, 10 years earlier than the first diagnosed case. Now, this sort of, we tend, based on your PSA, to recommend screening intervals. It used to be once a year. We're a little bit more lax now because we don't want to overscreen. So depending on your PSA, it may mean getting screened every year. It may mean getting screened every 2 to 3 years. Typically, we test or we screen until a patient's life expectancy is about 10 years. It's a challenging discussion to have, but there's a certain age you reach that testing for certain things may cause you more harm than good. So that's certainly a shared discussion with your urologist and other healthcare providers to have. In general, though, I will say that early stage localized prostate cancer typically is without symptoms, which is why we screen. So it's important to talk with your primary care doctor. Most of my patients are coming to me from my colleagues like Dr. Russell, who will have that initial discussion or get that initial PSA. But certainly you're also welcome to, if you just want to get your prostate checked and, you just saw your PCP and you want to schedule an appointment with me or one of my colleagues, that's certainly, that's allowed for sure.
Okay. Thank you so much. And I think just, a resounding theme here to get connected with your primary care physician for sure. So, okay, let's turn to Dr. Russell now. We'll take one or two more questions and then dive into our live audience questions. Dr. Russell, big question for you. Can type 2 diabetes be reversed? And what are some of the best ways to take care of yourself for someone who has diabetes?
Yeah. So big question. Lots of people in our audience, lots of people in the United States, diabetes. And diabetes, for the most part, is due to the death of some certain cells, some beta cells that live in the pancreas that produce insulin. So curing diabetes, really, we don't do all that well at curing diabetes. And actually, if you had a big weight loss surgery, there are some weight loss surgeries that actually can cure diabetes. The big thing is the people who have prediabetes, which is a large percentage of our senior citizen population. And you can really make huge differences with that 5 to 10% weight loss, which is probably in most of our realm for actually making some changes in our life. So diet and exercise, some of those other things, some medicines can really help. But by the time someone has prediabetes, you've lost about 50 to 80% of these beta cells. So the time to act with diabetes, because we worry about so many of the complications, is in the beginning. And I think when someone like myself, a clinician like myself, tells someone they have diabetes, no, I don't. I think we make a lot of excuses in the front load. And if we can really get our sugars under control in the beginning, we are so much less likely to have eye disease, to have vascular disease, to have neurologic disease. So really, it's one of these things, if someone tells you your blood sugar is elevated, to really act and make some of those changes, get on some medicine. And a test called your A1C, a red cell lives about 90 days. And we kind of look at the amount of kind of sugar coating, for lack of a better term, that these red cells have. That gives us an idea of what your sugar is over those last 90 days. So if you have elevated blood sugar, you should know what your A1C is. And really being that kind of personal owner of diabetes or prediabetes and being ready to make the changes you need to make.
Okay, thank you. We got to act fast and take it seriously. So thank you for sharing that. All right, so let's turn to our live questions now. We've been receiving a bunch, so excited to dive in here. Dr. Russell, I'm going to start it with you. Sorry, not giving you much of a break there.
Okay, I'm ready.
Okay, so question from the audience. Whenever I drink anything, I immediately have the urge to cough and frequently must cough. What could this be, and what type of specialist should I see to find out what this is?
Yeah, so cough, I think, is the number 4 reason that someone sees someone like myself. So there's kind of acute cough, there's subacute cough, and there's chronic cough. Chronic cough is a fairly big problem, happens more in women than in men, and it can really have many parents, right? So cough can be related to some gastroesophageal reflux. It can be related to some postnasal drip. There's different doctors who are kind of cough doctors. It could be a blood pressure medicine, right? So there's some blood pressure medicine called ACE inhibitors that can lead people to have chronic coughs. So someone who is coughing in the process of swallowing, I might find someone in the GI range for more of that, as someone having some swallowing issues and things are going down the other side, or certainly some ear, nose, and throat otolaryngology can also look down. So one of those 2 physicians might be the area that I might look at for this cough that's related to swallowing.
Okay, thank you so much. Some helpful information there. All right, Dr. Gamella, let's turn to you. A question from the audience. Can you talk about cervical cancer screening recommendations by age? Is it true that women don't need to screen for cervical cancer after age 65?
I was
Oh.
going to say that, yeah, probably a better question for Dr. McKiley.
Dr. McKiley?
I think that's me.
Oh,
But Dr. Gamella did tee me up really nicely for this, which I really appreciate. So whenever we discuss guidelines for any sort of cancer screening, they are just guidelines and they're based off of the general population. Now, Dr. Gamella mentioned earlier this idea of kind of this 10 years, of life expectancy past when a cancer screening recommendation ends. Cervical cancer screening actually will be tailored specifically to you as the patient. One, the virus that causes cervical cancer, the HPV or human papilloma virus, takes many years generally to cause cervical cancer, which is one of the reasons why the recommendation is currently to stop at 65. But the other thing, which is what we were talking about earlier with prostate cancer, has to do with life expectancy in general. So actually, although we might say that for some people, certain cancer screenings might end at 65 or 75, that will be tailored to you once you discuss it with your providers, just to really go based on your lifestyle, because, we want you to live a long, happy, healthy life for as long as possible.
All right, terrific. Thank you. All right, Dr. Russell, I know this is you because we are touching on the theme of primary care physicians again. Can you talk a little bit about how you view the role of a PCP and what advice do you have for a patient if they're struggling with their current doctor-patient relationship, specifically when it comes to receiving a timely response to concerns? Oh. There you go.
I think it's really important, and sadly, I'm going to be a little braggadocious that primary care, the doctor's only proven to add to the lifespan of the average American. So I think you should have as good a relationship with your primary care doctor as you do with your mechanic or the person who cuts your hair. And I think one of the things is actually going in routinely. I think you and whoever's caring for you get to learn a little bit about each other and things like that, and kind of understand what are people's philosophies, how do they view care, and even communication strategies. We're all working on a computer right now, and Jefferson has a wonderful patient portal, and it's a nice way to be able to relay some of your concerns to your primary care doctor. Maybe not every hour, but certainly for a lot of us, that's an easy way for you to really verbally give really a lot of information. Now, your clinician on the other end might just coming in, but at least you can relay all your concerns. And I think oftentimes when we get a phone message, it's been distilled down to a sentence or two. So I think having that relationship with someone, I think is really important. You can vote with your feet, right? So if someone isn't connecting with you, Baskin Robbins has 31 flavors. Not everyone is right for everyone. And find that person that you can actually be honest with, can communicate with, and figure out which is going to be the best way for both of you to communicate. But I think the portal is really supplanted the phone, is a really better way to touch base with us, because we can attach some things there, we can put some further information, and we can even forward some of your information on to say, hey, can you set up an appointment for Mrs. Smith?
Okay, thank you so much. And sounds like just being an advocate for yourself is important in order to get that relationship that this person might be looking for. So thank you. Okay, Dr. Gamella, we're going to go back to the Botox news that you brought up earlier today, or earlier in our discussion tonight. So regarding the Botox injections, how long do Botox injections last?
Most of the time, it takes, once you inject it, it's not an immediate effect. It can take a couple weeks, but it depends on the patient. It's usually several months, just like you would imagine Botox is, or if you've had Botox in other places. It's not permanent. It does need to be repeated, but in general, 3 to 4 months. Some patients get longer effect from it, though.
Okay. Thank you. Follow-up question for you here regarding bladder slings. Question from the audience. I had a bladder sling lift 6 years ago. It helped, but I still have an overactive bladder that seems to be getting worse. I'm 65 and I'm still struggling to urinate comfortably. I tried bladder pills, but they seem to have made it worse. What should I do?
Yeah, and it's tough without knowing the exact type of sling and doing a physical exam. But I would recommend that. And sometimes slings, while very effective, over time can either loosen or sometimes in rare cases erode into other tissues and cause symptoms. However, you bring up a very good point where many times when you treat one form of incontinence, which slings are used for stress urinary incontinence, it sort of unmasks urge incontinence. So like that's why I mentioned that many patients have a mixed picture. So the question for you, without knowing all the tiny details, would be, not knowing what medications you've tried. There's, again, 30 different types of bladder antispasmodics. Some work better than others. I would recommend all the dietary recommendations I had mentioned before. And then ultimately, I would say visit your doctor if you haven't, who placed the sling, to have just an exam to make sure that the sling is still okay, and it hasn't started to erode into the urethra, which sometimes can unmask some urinary symptoms as well.
Okay, thank you so much. All right, let's turn to Dr. Russell. A question for you. Looking for advice here for controlling or preventing migraines.
Wow. So a great question, and certainly something that causes an awful lot of kind of suffering, not necessarily mortality, but certainly causes suffering in people who have migraines. So I think there are two categories of medication. There are medicines you can take to prevent migraines, and there are medicines you can do once a migraine happens. So basically a smoke detector versus a fire extinguisher. In the way to prevent migraines, one of the big challenges with migraines is actually caffeine. So if you take, there are some over-the-counter things like Anacin or Excedrin that might have caffeine in them that helps in the short term, but when the caffeine wears off, people can get migraines. So one of the things I'll talk with people about as a preventive thing is really trying to limit themselves to that single cup a day, and then kind of watch other things that you're taking that have caffeine in it. For people who don't want to jump on the medicine bandwagon, riboflavin, B2 at 400 micrograms a day, 400 milligrams a day, excuse me, can really be a helpful thing for preventing migraines, getting enough sleep, etc. When people have migraines, depends on how often it happens, right? So if you just need to take some anti-inflammatories and kind of take it easy and get into bed, and it happens once a season, maybe that's just the limit that you have, and maybe you don't want to take a medicine every day. But there are that 5 or 6 really different categories of medicines you can take for migraines, and there's been some very exciting things that have entered into the migraine space, including botulinum toxin. Botox is also one of these kind of medicine that can help prevent. So there are a lot of things to do. Jefferson has a wonderful headache center, as well as having one up at Abington at our Warminster campus. So there are some really great people who all they do is migraines, but certainly your primary can at least get you started with some very available and very helpful things to do.
Okay. Why do I feel like I should cut my caffeine intake after this? But thank you. Appreciate it. Okay. This is for any doctor, so feel free to chime in. I have abdominal pain that radiates from right side to back and around to left side. My PCP and upper GI docs have exhausted options and medications. Any advice for next steps?
I think that's in Patrick's space a little bit, if it's kind of radiating to the back on the right side. So Patrick, do you want to talk about kidney stones and things along those lines?
Of course. I mean, kidney stone pain classically can radiate from the flank down towards the groin. Obviously, as I mentioned, just like low back pain, there's 1,001 different reasons for abdominal pain. So not knowing sort of, obviously the right upper quadrant, GI tends to have a play as well. If you've seen blood in your urine, it's associated with nausea. Those are common signs and symptoms of kidney stones. If you have a family history of kidney stones and you've never had that looked into, certainly kidney stones do tend to run in families. So it'd be something that can easily be checked, typically with just a simple urine test to see if there's blood in the urine, which can raise suspicion. And then, starting with an ultrasound. I'm sure though you've had an ultrasound with the right upper quadrant pain. So usually with the right upper quadrant ultrasounds, they do look at the kidney. Where it can get challenging is if you don't see any changes in the kidney, which you don't necessarily see them unless you're actively passing a kidney stone. So.
Okay, thank you so much.
And I mean, I think that these can be a little bit of a challenge, and I think pain sometimes can be a challenge because it can sit in so many of our, different camps. And certainly if someone is of the appropriate age, I'd had talked about kind of making sure you're caught up to date with your colon cancer screening. When I was kind of a young doctor, once upon a time, they used to talk about an ice pick thing. And whatever you could touch with an ice pick in the area where you're having pain potentially could cause pain. So someone could have pain in their skin from shingles. Someone could have a broken rib. Someone could have a problem with their gallbladder. Someone could have a problem with their kidney, their liver, their diaphragm. It could be radiating a nerve around from the back. So there certainly are a lot of things. And if you've exhausted one area, certainly there are some other organs in that area that you could look into, because the pain isn't kind of a normal thing and that is your body telling you something. So certainly kind of work, might be someone like Patrick, who's kind of, if they're thinking about kidney stones, etc. But pain is your body telling you something.
Absolutely. Thank you both. Okay, we have one last live question. This can be for any doctor, maybe Dr. Russell, if you want to hop in, but feel free to take it away, whoever wants to. So what daily steps should I take, aside from fiber, to address chronic constipation and mitigate discomfort? What approach does Jefferson have to addressing this issue in their GI department?
I mean, Jefferson has a kind of a world-renowned kind of GI department. So certainly that is a great place to start. Are you drinking enough fluids? Are you taking in enough fiber? So a very interesting thing I learned once upon a time is ancient man ate 100 grams of fiber. I don't know how they know that, but somehow our paleontologists figured that out. We're supposed to eat 30 grams of fiber. The average American eats 10. So fiber isn't medicine. It's non-digestible plant material. It's not hurting you. It's not changing your bowel. It's not changing you. And there's lots of great sources of fiber. So can you figure out some way to add 10 grams of fiber to what you're doing? That'd be 2.5 apples. There's lots of cereals for this. Are you drinking enough fluid? You certainly need some fluid. And really walking can be a great help for that as well. And then there certainly are lots of medicines. So we heard about treatment of cancers, right? A lot of cancers, people are on pain medicines, and those medicines can be very constipating. We have heard about incontinence, and some of the medicines that can help from incontinence can also lead to some constipation. So certainly looking at your pharmacopoeia, the meds you're taking every day certainly might be one of the things to think about. But certainly our other panelists deal with lots of problems with more chronic constipation in some of their individual areas.
All right. Thank you so much. If anyone else wants to weigh in, but certainly a nice reminder to get your fiber, walk, fluids, all the basics. So thank you for that. Okay, we do have one follow-up question that just came through, potentially for Dr. Gamella, but again, feel free to hop in. Does the gastroenterology field tailor treatments and care to patients who experience pelvic floor issues, especially those faced by women? How do we address care that addresses both issues together?
So I guess I am assuming they mean, constipation as well. I mean, the pelvic floor, is really a hammock of muscles that we tend to not think about. We can, most people don't know how to exercise their pelvic floor. A lot of people have stress that manifests in their pelvic floor. So, when we talk about care of pelvic floor chronic conditions, it's really a broad term. It can be, there could be sexual dysfunction, urinary dysfunction, as we've talked about a lot, bowel dysfunction, and then acute and chronic pelvic pain. And one of the most challenging things we treat, because a lot of the times we can't find a specific cause for it. So Certainly, we do have a lot of different, we subscribe by really a multimodal approach, especially in the setting of sort of chronic pain that we use routinely. We have teams of urologists, pain specialists, and something that a lot of people aren't aware about is pelvic floor physical therapy, which are, they're physical therapists that have a special training and focus in pelvic floor dysfunction. And they, through working with them, can really teach you the skills on how to isolate, relax, and strengthen. Some people need to strengthen their pelvic floor, some people need to relax their pelvic floors. And pelvic floor physical therapy is something that's very underutilized, which I tend to refer a lot of my patients to because most of them experience a lot of great effects. There are also complementary and alternative medicines that some people have looked into. It's not a huge amount of data, but there is some data to suggest that acupuncture can be beneficial in some of these settings as well, including urinary dysfunction and pelvic pain.
Okay, thank you so much. And I think with that question, we'll have one last question this evening for all the doctors. Would love to hear, what are your goals for everyone listening in on this webinar tonight? What do you want our viewers to take away from tonight? Dr. McKiley, let's start with you.
Thanks. I think my goal is to provide everyone here with tools that they need to basically advocate for their own health, their own well-being, and also specifically for disease prevention. I hope that you know that we are always available to you to discuss disease prevention, to discuss potential risk, and to help you or your loved ones navigate disease. And I know everyone says this, but there's never a question that's too small. So I believe that, Dr. Russell was saying this, connecting with your provider is so important, and open communication with your medical team. So not just, your doctor, but their nurses, the therapist, the whole crew, the person who rooms you in your room can really be important parts of your care. So I hope that you feel a bit empowered at the end of tonight.
Okay, thank you so much. Dr. Russell?
I think it's really important, if you think about it, we replace our automobile, if we own one, every 3 years, 5 years, 8 years, and we got one body. And if you were only going to own one car for the rest of your life, you'd wear booties to get in it, and you'd shine it, and you'd put fancy gas in it. You have one body, and really treat it as best you can. So there are some guidelines, and we heard about the cancer guidelines, and certainly you want to do that. 55% of cancers are cancers we don't screen for, though. So listen to your body. Even if you're doing everything right, get your blood pressure checked. Know what your ideal weight is. Get some exercise. Eat right. Try to kind of work on your depression and anxiety, and enjoy today. I think that that's really important. Tomorrow's not promised to any of us. So we should enjoy the gift that is today.
Wonderful. Thank you. Enjoy today. And Dr. Gamella, to close us out.
Yeah, I think it's real simple. If you have a concern, as minor as it may be, it's not, as Dr. Russell mentioned, I'm a big fan of the patient portal. It's a lot easier to have a back and forth HIPAA secure medical messaging system with patients, and you have a relationship with someone and something comes up, it's easy to send a message. It can be challenging, in and out of the operating room, seeing patients, to return phone calls and messages. So please, if you have any concerns, sign up for the portal and develop those relationships and reach out.
All right. Well, thank you all so much, Dr. McKiley, Dr. Russell, Dr. Gamella, for your time this evening. Your advice and your wisdom was invaluable. A lot of great information was shared about the importance of not delaying care. So thank you all for attending and submitting such interesting and important questions. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Is there another time that works better? Any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. Be sure to visit jeffersonhealth.org to stay up to date on upcoming classes, events, and webinars just like these. We have a webinar coming up in October about understanding back pain and spine surgery. We'll post that information shortly. And for more health content, including expert Q&As, patient stories, latest research, and more, please visit thehealthnexus.org. A recording of this event will also be sent to you so you can rewatch. And if you would like to view other wellness webinar series events, please visit our Jefferson Health YouTube channel. If there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining, and be sure to stay safe and healthy. Have a great night. Thank you.